Let's say you're on shift and you get your typical patient who presents bradycardic and acute renal failure and is hyperkalemic, not responding to atropine. Well, on top of your typical management for hyperkalemia, I want you to also consider BRASH Syndrome, which stands for Bradycardia, renal failure, AV nodal blockers, shock, and hyperkalemia. This is not just 5 separate problems, but instead one vicious cycle that we can refer to as the Bradycardic Black Hole. It usually begins with some sort of renal injury, which is typically hypovolemia or medication-induced. The kidney injury leads to hyperkalemia, which can lead to bradycardic arrhythmias, which can lead to a shock state, which can cause worsening renal hypoperfusion, and thus we're stuck in this cycle. The cherry on top is that these patients are often on medications that cause AV node blockade, such as beta blockers or calcium channel blockers, which can then act synergistically with the hyperkalemia and worsen the bradycardia. You should know that atropine, transvenous pacing, and your typical beta blocker, calcium channel blocker overdose protocols probably won't work. Instead, focus on removing the offending medications, shift the potassium, and stabilize the cardiac membrane, and treat their shock state with IV fluid or pressors. Keep this in mind next time you have a bradycardic, hyperkalemic patient in acute renal failure so that you don't get stuck in the bradycardic black hole. And that's all with today's Space City Quick Hits Chalk Talk. See you guys next time.